This is the Zero Downside Podcast, brought to you by MOABTexas.com.
Hello, everyone, and welcome to another episode of the Zero Downside with Mike and Dr. McKenna. And today we're going to be going over nerve ablation for knee pain and also discussing the science behind it, how it works, the ideal candidates, and then going into how we combine it with our regenerative therapies with peptides, bone marrow, amnion, kind of do it as a combined therapy, and then some patient experiences. And so I'm going to kind of let Mike take it off for our first portion segment.
Absolutely.
He already
Here
said
first,
that.
I want to point out that it feels like Hannah just gave us an outline on purpose to make sure you and I stay on topic.
I know. It's almost like we have a reputation for not timing out the episode very well, right?
It feels like that she purposely put the outline out there first so that she can give us the look.
You know, and Mike already set my expectations that we'll probably lose track after segment 2, but
I feel like
as long as we try,
if there's
that's
4
all I
bullet
care
points
about.
on a page and we got through 2 of them, it's a win.
It's a win.
Yeah. If I get through making the things important that I wanted to be important out of it, and everyone's not telling me to look at the clock the whole time, I think we did okay.
I like it. Well, hey, now that we've talked about staying on topic, let's go ahead and just
And try to do
Yeah.
that.
and just push that aside for just a minute. I know, Dr. McKenna, we have our pre-show meetings, and one thing that we wanted to get across is the flow of the show. How we're going to address things and topics, and we want to be engaging for the viewer. We want to be engaging for our patients and our audience, and part of hosting and being a part of a podcast like this is learning to engage your audience and give them information that's of value, and it's also entertaining. So we want to show more of who we are, and I'd like for Dr. McKenna just to touch base on that.
Yeah, because so far I've hated every podcast.
Come on, not every one of them has been terrible.
I've hated 90% of all of them. But the parts that I like, because I know me, and I know that my goal is always to, you don't want to be the Instagram plastic surgeon that all the other plastic surgeons think is an idiot, and you look at some guy doing some TikTok dance and think, oh, it's all marketing. He doesn't really know what he's talking
about. We've seen it.
Oh, I got moves.
You've got
crazy moves. I have 3
bongos
daughters. I
and
have
moves.
crazy moves. I have moves across 3 generations of daughters. So now some of them go back to the 70s and 80s. So if you've seen old movies, you may recognize some of those dance moves. I'll just say. But
Lord.
from a serious standpoint, I work really hard to get as much information out on the table as possible. And my goal is always, from a professional standpoint, that I want to make sure people feel comfortable with my level of expertise. I'm hoping that in these first few episodes, it's come across that we actually know what we're talking about. What I really wanted to do in those episodes was really, though, talk to patients and let them start to understand or get an introduction to some of the technology and non-traditional approaches to care that are out there. I think we've already talked a lot about how our clinic works really hard to be technologically at the top of the heap as far as all the cool new toys. I think we understand that I'm not
I think a lot
a
of our
non-doctor,
knowledge comes in too, because you're such a patient advocate. Like, you want people to have the knowledge to make an educated decision, because you just don't know what you're getting these days in a hokey, regenerative
I genuinely
stem cell
want the patient
thing.
to understand everything about what we're doing and why.
Yeah,
right?
so we're really
and so
trying.
I work really hard to educate the patient. My problem is, I think that a lot of times when you're talking and other physicians are going to be watching it, I'm used to lecturing to groups of physicians. I'm used to talking to residents, med students, teaching the procedures we do. I mean, there's several of the procedures, that's how Mike and I met.
Very
There's
detailed.
a shoulder instrumentation that I developed back in the day, and the only one doing them at the time in the country was the guy that developed it. And so we taught a lot of physicians how to do procedures. And so a lot of those more technical focused lectures are the pattern I tend to fall into when you put a mic in front of me. And that's not really, I don't want to talk above everyone's head. from it, and it's not that someone's not smart. It's just they're not maybe experienced in the same field we are. And so what I don't want to do is do a podcast to doctors about something they're going to hate anyway, right? I mean, Western medicine does not espouse the approaches that we do that are patient-centric. I think Western medicine is way focused on diseases and not health, and they're not focused. The patient really doesn't have a spot, right? Most physicians work for someone that tells them what to do, and those patients are looked at. I hate any business that refers to a patient as a client. I hate any, and I think that from a big pharma standpoint, if they made people better, they lose all their clients. And so when they don't, they keep their clients because they continue to medicate them. So for me, I think that we try really hard to not do that. We try to focus on health. So I think, long story short, I want to make it where people feel more. I want the show to be more approachable to a layperson looking for help, and to know that there is some non-traditional approaches out there that you're not going to find out about on Google, Bing, or Yahoo. You're not going to find out about from most of your family practice or internal medicine or orthopedic surgeons. But there is a big uprising, I think, and it's starting really on the family practice side, right? Not on the surgical specialty side. But there's a big uprising because I think that the family practice physicians and chiropractors and nurse practitioners,
there's even dentists I've seen recently of uprise of just natural healing.
The people that are actually having to approach people all the time.
Yes.
The ones that develop a doctor-patient relationship, right? So you are probably way closer to your family practice doctor than you are your surgeon. You're probably way closer to your PA, the nurse practitioner, your chiropractor. The people you see more often are probably the ones that are more fed up with Western medicine than most patients are yet, because they're limited in their approach to people. And so I think there's a huge move by that subset of medical professionals that is really looking hard on a patient's behalf, because they know when they send someone to people that are taking care of them with that stereotypical flowchart of care, that doesn't work. And when they have to come back and see, and they're the ones who have to deal with the repercussions of it, right? They don't come back to the surgeon 50 times over a period of a year, but they may see their family practice doctor for chronic management or medications every month. And so I think that my job is more to expose people to an alternative thought process when it comes to healthcare problems. And if there is one, and usually, unfortunately, there is more than one, right? There are plenty of alternatives outside of a total knee arthroplasty.
Exactly. And speaking of one,
yeah, so I think that
nerve ablation is one of them that a lot of people don't know about.
For sure. And I think that especially when we talk about total knee, I mean, there's a really significant lecture, and we talked about it last night, where I'm on a stage in Vienna with another orthopedic surgeon, and we're talking about bone marrow aspirate concentrate and treating osteoarthritis and trying to prevent total knee arthroplasty. And I know that lecture's out there on the internet, but there's one of the question and answer sessions, I think it's near the beginning, because I thought lightning was going to strike the guy next to me in a chair, where we're trying to make the decision. The question from the audience is, how do you know that stem cells or bone marrow aspirate concentrate, let's define that term, you're taking where do you source your graft? We source it from our patient in that instance, right? Now, is that sourced graft from you the best graft in the world? No. That's because if you're metabolically compromised or older, we're going to use some postnatal tissue graft to augment your bone marrow's ability to do what it wants to do. Okay, we've covered that a lot. Hopefully you've got that by now. But the question from the audience is, when is it okay to talk about using bone marrow aspirate concentrate to treat osteoarthritis versus when is it time to replace the knee? And the answer from the first surgeon was, well, as the best joint replacement surgeon in the world, which I'm sitting next to him and we're speaking to 400 other doctors. And all I could think is, I'm scooting my chair over to the left a little bit when the lightning comes through. And he says, I just tell the patient, and he's very heavy, thick Italian accent, and says, I just tell the patient, we should do this. And if that doesn't work, I will tell you when it's time for me to replace your knee. And I was gut shot. now it's my turn to answer the question.
Yeah, how do you follow that?
Man, well, it's certainly not hard to see more human and approachable after that, right? So in one way, the table's set up for me pretty well, but in the other way, it's like, I had to catch my breath a little bit first, because what I wanted to do is reach for the fork in front of me and stab myself in the eye. But
as the second best,
but we're speaking to 400 really renowned, Eastern, Western, Middle East physicians in that room, and I said, well, in the U.S., I work really hard, and I think medicine has a history of being very paternalistic. And in the U.S., what we do is, if someone, for me, the total knee patient in my mind now is, and I know you guys have heard this a million times, is someone that hurts all the time. They're having to take narcotics. They can't. It hurts even at rest, so they have trouble getting rest and sleep, and that nothing else helped. And I think that the nothing else helped is important, because there are plenty of stones to turn before you talk about total knee arthroplasty. Do I think that total knee arthroplasty is a bad surgery? No. I developed the instrumentation to put in the knee that we use a really long time ago, and I'm pleased with it. Do I think everyone needs a total knee? No. And so I think that there are plenty of people out there that they look at their x-rays and say they need a new knee. And when you talk to the patient, they're not even having nighttime pain. They're walking every day. They're not even on narcotics. And my question to that patient is always, why in the world would you have a total knee arthroplasty thinking it's going to mildly improve things, when it's a 6 to 9 month recovery for a lot of people? And there's a risk of blood clot, pneumonia, heart attack, stroke. Now, I will tell you right out, that's the surgery that made me want to be a doctor, because I watched it change someone's life. When I was 14 years old, I watched it change someone really important in me's life, my Aunt Lillian, God rest her soul, who was more like my grandma, because she's my grandma's sister, and we were, as a Native American family at that time, like your very big family core kind of thing. But she was, one time at Thanksgiving, she said, I'm just ready for God to call me home. And I just remember it breaking my heart, because she was having so much pain she couldn't walk. And that was over Thanksgiving. And then by that summer, she had both knees replaced, and she's running around, she's gardening again, she's got her whole life back. And I just remember thinking, man, if you have to work, what a great way to make a living. Like, I want to do that, right? And so, but that was, I didn't know surgical risk, limitations, patient decision-making at that time. I just thought it was a really cool surgery and a great outcome.
So looking at nerve ablation, right? One of the questions I get when people ask me about it, which, you're in the room next to me, let's ask the doctor, right? But one of the questions I get is, okay, if I get nerve ablation, does that mean I can't bend my leg, right? Is that a motor nerve? Is it a sensory nerve? So can we take a step back and discuss what nerve ablation is in this process as an intermediate step?
Yeah, I think this is important, because even when you talk to another doctor about this procedure, which we've done a lot of other doctors this procedure on, because they didn't know about it, right? And I think that the question is, am I going to feel numb? Or what if, here's the biggest question with that. Does it make it not hurt so much that I'm going to tear it up and not know? No. If you need the procedure, it's because you hurt all the time anyway. If you hurt all the time anyway, and it's keeping you from doing things you want to do, your only goal with surgery is make it not hurt so I can do stuff, right? I want it to not hurt, and I want it to be functional. So the ablation that we talk about using radio frequency to ablate the sensory nerves around the knee is a 10-minute procedure. Now, you need to be asleep, because I will tell you, we have this machine in the office. We have a private OR in the office with anesthesia. But my goal was, man, if I could figure out a way where we could do this for people without anesthesia, we could really help a lot of people. There's some people that anesthesia doesn't want to put to sleep. There's some people that aren't healthy enough to be put to sleep. They're certainly not healthy enough for a total knee. Man, if I could find a way to do a block, do a genetic block, we'll do all this stuff. If I could do this procedure for someone that was awake, bam, like that may be all we do, is just take away everyone's knee pain. We'll just stand on a street corner with this machine saying, pull your car up, right? I mean, that kind of a mentality. And so I stuck that probe, we did my knee, prepped my knee out, stuck the probe, and the hardest one to do is the one that's in the middle of the quad above the patella. So I stick the probe in, and the machine has to go for 2 minutes and 45 seconds at 4 different sites. And we have CRM visualization, and we make sure, because those 4 sites, you can't just randomly pick where you're going to put it. There's a very specific way to do the procedure, and I wouldn't have, it's one of those procedures where I wouldn't want to be in the first 5-10 someone did, right? I think that
that's understandable, right?
Really, yeah, for sure. I mean, I think it's really hard to get the kind of results we get if you haven't done a lot of these. So for me,
precision in this is
it's about the precision, right? So we have CRM, we isolate where we're going to be. I've marked the site. We do a pretty little block. We put the probe in. We did all that to me, and I kind of get that probe down, and I had her turn on the machine, and I'm looking at the machine, and I'm thinking, okay, if I can make it through, like we got 4 of these to do. All right, ready, go. And man, at about a minute and a half, I just thought, there's no reason for me to not have an IV put in and go to sleep. Yeah. You tapped. Oh, yeah. I tapped out. Like, Mike's a jiu-jitsu guy. So he, when he says he's tapping out, it's a big deal. I tapped like about a minute and a half. I'm like, oh, heck no. Like I'm out.
That's about a minute and 20 seconds longer than I would have let you do that.
Yeah. So Well, here, again, one of the things I hate about on the other podcast, I say, here's the cool part a lot, but there are really,
you say, here's the cool part. And what do I always tell patients?
Yeah. Well, for me, here's something really genuine. There are a lot of cool parts to what we do, right? And there's not a lot of cool parts left to being the patient going to the doctor. There's not a lot of cool parts left in medicine anymore for the physician if they're being told what to do by some standard protocol, flow chart that's made by your boss, who is owned and a part of the Western medicine institution that doesn't want to talk about anything that's not reimbursable, has a code, and that makes the system a lot of money. Well, this isn't one of those procedures, because we thought insurance approval was a thing. As it turns back, a lot of patients get called back on. The hospital cash pay price for the procedure is around $15,000. That probe's around $2,000. Why would someone charge $15,000? Well, because you're walking in their OR, because you're part of the hospital system, because it's a big deal. The cash price on that procedure done in a private OR with great anesthesia.
It's a fraction of the cost.
It's silly not to think about it, because you're probably honestly going to be paying the same, even if your insurance does approve it. You're probably paying. That's how we worked on trying to come up with some of the pricing. Yeah,
is because most people with high deductible insurances could have this done cash pay, and not have had to go through the hassle of pre-cert, pre-approval, auth, it not getting auth, having to appeal it. The procedure gets being put back, and when you do it at a hospital, you know what they won't let you do with it? Anything else, and they'll only let you do one knee at a time, because the probe's only reimbursable on one knee. They won't let you do 2, and you can't inject anything in the knee while you do it.
Let's take it back a little bit. And so unfortunately you have to go to you have to go to sleep, unfortunately,
right?
And therefore,
fortunately, because I think that when people wake up on propofol, they go to sleep with the painful knee.
Yeah, but it's still for 10 minutes.
They wake up in the recovery room, they feel genuinely better. We don't use a lot of narcotics in our clinic unless they're needed, but propofol as an IV anesthetic is a great drug. And what's published on propofol is it's like taking an 8-hour nap, right? Like you feel, most of the people
that REM sleep is great.
Most of the people that we do this to wake up and go to lunch, right? When we did this to my mom, which was life-changing, because she would have never let me replace her knee, because I replaced one of my dad's knees 20 years ago when he was pretty healthy, and he did great. But it's so good that he put off the other knee, because he thought, look, I'm doing so much better with one good knee. I'm just going to do this for a while. 20 years later, he needs a knee on the other side, and he's not in the same health as he was when I took care of him. And I set him up with the guys they live out of state, and had him set up there where his cardiologist is at the University Hospital. And he had a stroke, got an infection, and was never the same, and passed away within the next 2 years because of what that procedure did to him. So after my mom taking care of my dad at home by herself for 2 to 3 years, she was never, ever, ever going to have a total knee. And
Well, yeah, after watching that, how could you go, hey, this sounds like a great
this is
idea.
a great idea. I want to do, let's jump
I want to
right
go through
in,
what
right?
exactly.
I want to go through what I had to take care of my husband through that she'd been married to for 50 years.
That's understandable. I think a lot of people that resonates with them.
Yeah. So she didn't want to do it. So I'm stuck with, she goes, well, you can just put cells in it. And I'm like, okay, Mom, like you're bone and bone. You can't stand up.
Can you see him arguing with Mom?
Not really, right?
No.
I acquiesce.
I think
It's
that
like
was-
watching me argue with my kids.
That's
You've
probably
seen
the
that.
shortest conversation you've ever had with your mom.
Yeah.
Was
I can't even
Shortest
argue
argument you've ever
effectively.
had, actually,
Yeah,
probably.
I don't even really argue. I actually never argued with my mom. I did what she told me to do.
Yeah, exactly.
Because I was a good boy. Yeah.
Gold star.
I got gold star from my mom, but she kind of snickered at when I was mischievous. Like my mom was amazing person. But no one in this room's ever seen me win an argument with my 10-year-old, and for sure not winning an argument with the 26-year-old attorney that I raised. And
tried.
the soon-to-be medical student that I raised is already convinced she knows more than me. So I don't win arguments. But with my mom, so I go on the search for a procedure. So we find ablation therapy because my goal was I need to make it where my mom didn't hurt. Like I don't care. Her X-rays are bone on bone, but now she's getting crepit. Now she's getting to the point where, and this is what happens when someone needs total knee, you're doing a really big surgery on someone that's not metabolically or mechanically really fit anymore because they've hurt long enough that it's hard to get up and down out of a chair. It's difficult to even sleep and get an appropriate amount of rest. If you can't hardly even get up and down out of a chair and you can't walk without pain and discomfort, it's extremely difficult to stay in shape. And so you're putting a total knee in someone after years of that, and they think they're going to get better right away. Well, you're not. Your joint's going to look prettier on X-ray that day for sure. I made an ugly joint look really pretty. That's the surgeon's goal. The patient's goal is to be able to get up and down from a chair, walk, and be able to do stuff.
Not hurt so much.
Yeah,
where you're inhibited.
Yeah, and we've challenged someone with the length of time this has gone on. So they're not as strong, they're weaker, and they're not as fit. Not a lot of 19-year-olds with great core come in and say, "Hey, I need a total knee," right?
Yeah.
So, in a long story, but we find ablation therapy. We bring my mom in. I do inject her knees with cells, but I didn't figure it was worth putting her asleep to just do that. So we put her asleep, do the ablation on both of her knees, and as she walks out of the clinic, she comes back in to get my nurses who have all adored my mom. My mom was like a mascot of a clinic. She comes and gets the staff. She goes, come here. And she makes them go outside, and she makes people watch how she can get up and down off the curb by herself. Okay, first of all, I'm literally heartbroken because I can't believe my mom waited till she couldn't get up and down off a curb by herself to let me even take care of her. So heartbreaking that she didn't feel like she had any options for that. But the fact that then she's getting up a curb by herself and was so excited about it immediately after the procedure. It wasn't one of those procedures that we have to get her back in shape. We have to do all the pain management. We have to get her through that. She's going to be in the hospital. It was literally, we went to lunch, right? And so with that being one of our first experiences with a device, I think now our original plan with the device was if you do it to what's published is if you do a ablation on a patient a month before they do a total knee, they use 50% less pain medicine over the next 2 years to get through the total. And 50% less pain medicine in someone that's, on average total knee in this country is done at 65. 50% less pain medicine means, now I think it's actually under 60 now, but 50% less medicine means a lot less liver dysfunction, a lot less renal dysfunction, a lot less mental issues, a lot less other medicines to treat the secondary constipation, depression, sleeplessness that comes with the narcotics, right? So you're not helping someone avoid taking a pain pill. You're helping them avoid like 2 handfuls of medicines and a dramatic surgical
You're
risk.
fixing the whole chain.
You're trying to take care of someone metabolically, physically, get them active, get them where they can walk, and avoid liver and kidney failure. So we initially our use with the device was before total knee. In our clinic, where we're not afraid to take maybe a non-traditional approach, what happened very quickly is patients would come in after that procedure to book their total, and I'd be looking at him, talking to him, hey, I'm Dr. McKenna, and the patient would be like, kind of sheepish, maybe not making eye contact, and I would finally say, what's up? Something wrong? Did it work? And they go, yeah, I feel great. Do I have to have a total knee? And my answer is always no.
Of course
right?
not.
You only have a total knee if what? Nothing else helped. You can't do daily activity. You're having to take narcotics. You can't even sleep at night. You have pain at rest. That's a patient that needs a total knee. And they're like, well, I'm none of that now. Like, I have hay to bring in. Like, can we just let me get through hay season and maybe do it after that? I'm like, look, hey, I got a better idea. When you were asleep and I did your ablation, we put cells in your knee. Those cells aren't even growing cartilage for the first 6-8 weeks. Most of the cartilage growth happens between about week 6 and week 16. You're nowhere near as good as you're going to get from that injection until week 20, 24 anyway. Let's see what happens first. And like, well, I don't want to wait till after this wears off to have my total and then I'll hurt more. I said, you can repeat this. Like, if this makes 2 years of difference and you're doing everything you want to do, you're hauling your own hay, you're playing golf. For Dr. Stanton, all he wanted to do is play golf twice a week. And he got to the point where it was more and more difficult to do that. And so when we did his ablation, there's zero chance he was going to do a total knee. I mean, that's 4 years ago. He still hasn't, we haven't, to this point, we haven't repeated one.
No.
What we tell people is it lasts about 2 years and you can repeat it. But we still haven't repeated one in the clinic, and we've done more than anyone probably in North Texas for sure, right?
I think it's safe to say this is, and I know you shouldn't say this as a physician, but it's one of your favorite procedures to perform. And I think part of that from our perspective, right, watching in the clinic, is this is one of the few procedures that you can actually see instantaneous results. As soon as the patient wakes up, a lot of times, and you've talked about cells, right? It takes 6 to 8 weeks, and you've got a patient that they hurt coming in. You're going to do something, whether it's a shoulder or another procedure, and then on their way out the door, you're going, man, I hope they can just get moving enough to let the cells do what they're supposed to do. But with this procedure,
well, you never know what someone's reaction to cells are either, right? I mean, you have to be metabolically sound. Now, it's never going to hurt someone, and it's always going to make them better. Is it better enough is always the issue.
Yeah, and you've gone as far as to call this cheating, which I think we need to define that, right?
Yeah, I love any little, and I know sometimes I hate the word hack, but I really love the mentality behind it, right? Like, if you find a better, easier way to do something, I love that. Like, anytime someone gives me a lifestyle hack.
Even though that's like one of your lessons there, is you're always going to have an easy option. But in this case, it's a good choice.
Sometimes.
So how is it cheating, right? Let's dive into that.
Here's what, without saying, here's the cool part, but here's a really cool part. When we have people fly in for a procedure, and Hannah's trying to coordinate their flight and their hotel and help them with the timing on the visit and the MRI and the visit, when they get to the airport after the procedure, they're still in pain if they came in for cells, because those cells you're not as good as you get from that procedure for 4 to 6 months. But when they come in with a bad knee and they're on a walker, and literally we've had people wheeled into the clinic to the procedure room and walk out. Right. And so when they come in for just cell procedures or for surgery, like, there are people fly in, we'll do a knee scope, clean up, they have some big loose piece getting caught. I don't just want to waste their money putting a bunch of cells in their knee while they have a big loose chunk. So we'll stick a scope, take care of the loose piece, trim up the tear, get rid of whatever's causing their mechanical symptoms. And we'll let Mike bring it up in a minute, but we'll do that and then use the cells. But when they're not any better when they get to the airport than they were when they got to us yet, symptomatically.
They're just not limited by pain.
They're not. So we want them to get better, but they're still hurting when they leave. Now, when someone flies in for the same thing, but we add ablation to it in the clinic, they're on the airplane, and whoever sits next to them is going to hear about us, right? Because what happens is you're not as good as you're going to get with that procedure for up to 6 weeks. The nerve can continue to spread and die a little bit, but you're usually better immediately. And one of my favorite people in the world, and I don't know, won't mention his name maybe, but he ran for Senate, and I'm a huge fan. He's a conservative guy with amazing values and work ethic, and one of the most amazing athletes in the history of many sports, actually. His family, beautiful woman in her 80s.
Mm-hmm.
Yeah.
Roughly. Yeah.
Yeah. Was coming back in a wheelchair, has to use a walker to get up into bed. And she's old enough to where it's okay for her to, be cute, talk about, oh, you're such a cute dog. And so I said, look, here, and she's holding my hand. She goes, is this going to work? I was like, look, here's what I'm going to tell you right now. And I don't say this, but I said, I know how much it hurt to walk back here, but I will tell you that it's not going to hurt that much for you to walk. So you came back in a wheelchair. You're going to be putting weight on your knee. And her goal was, because within the last couple of years, she was walking 3 miles a day. She goes, my goal is just to be able to walk my dogs at 3 miles a day. I said, here's what I don't know if what that's going to look like, but I will tell you that the walk from the parking lot to this clinic, the walk to lunch is never going to hurt for the next few years with this procedure like it hurt before you're going to sleep. Like you're going to wake up and be able to walk out better. And you can't say that with anything else we've ever done. You can't say that with a total knee. You can't say that with a knee scope. You can't say that with just an injection of hyaluron or steroids or even an injection of the cells, because that's not how it works. They take a while to change the environment of the joint, right?
So you're buying time.
We're trying to make you less bad with those other procedures, but it takes a while to get as good as you're going to get from them, but not with an ablation. With an ablation, are you as good as you get when you first wake up? No. Are you dramatically better than when you went to sleep? For the first time ever? Absolutely. Right. Like, I will never tell that about a traditional surgical procedure, because you could have some swelling, you could have bleeding, you could develop a clot. There's all kinds of things that can happen after surgery. We do everything we can to manage those complications. We do a lot of surgery still through our clinic. But to have a procedure in your tool belt that can just make people not hurt is really fun. And there's a lot of people that don't even know about it. And so when we do an ablation on someone in the clinic, there's a lot of education process that, because the first question is it going to make me protect my pain so bad that I could really, really mess up my knee? Your knee's already messed up. Like, no, I just want you not hurt, right? And so, well, what if I tear something or break? Look, it's not going to protect you from the pain of a fracture. If you fall off the tractor and twist your knee wrong and break your tibial plateau, that ablation isn't going to protect you from that. No. The ablation protects you from arthritic pain, early bony collapse. And what it does for us is it gives us a chance for the cells to make a big enough difference that by the time that ablation wears off, maybe you don't need it done again, right? And for us, that's what we've seen. And we've done a ton. So for me, even just bad lateral patellofemoral pain, like we have a doctor that we all love that has a wife that has extremely bad patellofemoral disease, got to where she couldn't do her Pilates, and that was her stress relief, and she needs it because she's married to a doctor. But she had dramatic lateral patellofemoral joint, and I scoped her knee for the first time 25 years ago, and scoped it again maybe 15 years ago because she accumulates a lot of debris and it'll start locking up. She came back in thinking she's going to need another scope, but it's just really isolated but fairly severe arthritis. So instead of talking about lateral release or patellofemoral resurfacing, which is what we had talked that someday she was going to need, we just ablated the patella. She did great, right? It took 10 minutes. She didn't have surgery. We put cells in her, but like I didn't scope her. They put her to sleep, do the ablation, fill her knee with cells. That was 6-8 months ago. And she's in Pilates. She's doing well. She's dropping a lot of weight. I mean, she's getting back in shape. She looks great.
Just moving around alone.
Just being able to have access to movement without pain, right? Like that's what this is really about. And this procedure to not be mainstream and first line of defense for someone. I have a patient now that I think he's had 3 or 4 arthroscopies, a big failed ACL surgery. He's a college athlete. He's in the medical industry now. And I think that the way he wants to approach it, because he's finding it out, is he wants to go ahead and do the ablation because he's having a lot of pain. But he still has a lot of locking because he's got a lot of debris. But he wants to get the ablation done as quick as possible because he doesn't have time for the scope yet. And he's like, do I need to wait till after the scope? All I could think when we saw him this last week was, oh my God, if we ablate you before I scope you, how cool is that going to be if you can do a knee scope on someone with almost no pain and recovery time because they were ablated already? Because that's what happens with the total, right? The patient that comes in, it's all sheepish about not wanting the total. I told him, I said, look, if you do the ablation, you may not be symptomatic enough to even have the scope. And he's like, but his knee's cogwheeling, locking up. He has a lot of mechanical symptoms. So that's probably not going to happen because the ablation and cells are not going to get rid of the big mechanical symptom. So he knows he still probably needs a scope, but he needs some pain control to get him through the summer because he's really busy. So we're going to ablate him. He's going to do great. And then when we scope him, I can't wait to see, because we've never ablated anyone before knee arthroscopy. We have ablated a lot of people before totals. We've ablated a lot of people that decided not to have the total. But I think that, and for the most part, we do ablation as a standalone thing. Like there's no other plan. It's like your knee's really severe. If this didn't make a big enough difference, you need a total knee, but that you're at the end of the rope. That's all I got left for you. Oh, except for this, right? And so what I'm kind of looking forward to is seeing if we ablate him, how much easier does it make for him to get through a knee scope that is dictated on not just some little 19-year-old with a tear, but a guy in his 50s that works 100 hours a week, that's flying 3 days a week. Does this make him, like, what does it do with his return to work after knee arthroscopy? What kind of pain and swelling is he having afterwards? Like, I'm
curious how that
I can't wait to see how it goes, right?
We'll talk
Because
about it next
for the
time.
most part, we don't do this as a staged procedure before scope ever. Now, it would be really cool to maybe do it before some big ligamentous reconstruction, right? But I'm kind of looking forward to see how much pain relief do you get. I mean, you know what's going to happen.
You're going to do the ablation.
We're going to do the ablation. He's going to live with the mechanical symptoms like he has been for the last 10 years. That's exactly what's going to happen.
Probably why it hasn't been done up to this point,
which
right?
is, I'll tell you what, which is great, right? That's probably the reason we haven't done an ablation for a scope. Because even if I tell people, hey, we can take care of your pain, but if you're still locking up, we still need to scope you. I guarantee you what happened is that person is the same. It's like me and like you. If you take care of the pain part and I can go back to work, dude, peace. Like I'll see you when I see you, right? So I know that's what probably is going to happen. Yeah. We're going to make him better, and he's not going to have enough pain to pay attention to the mechanical symptoms, and he's just going to continue to stroll on down the road until that starts to wear off, and then he'll be like, oh, okay, I have to get a scope. Or, and it's as unstable as the guy's knee is, he's gonna. He literally has a handful of junk floating around his knee. Yeah. He's gonna have the ablation done. He's gonna way go past through the summer. I think he's scheduled to scope like sometime in September. He's gonna get into football season, and he's gonna be traveling to the games, and he's gonna end up waiting till after the holidays, probably. Or not, right? So the one thing this procedure does that I tell people all the time is it puts you back in control of your situation and decision making.
It buys you
right?
time.
Yeah, 100%.
Like if you're, the reason people feel so stressed about having surgery is because they feel like they have no options and they feel like they have to. If I make it where you don't hurt, you're literally back in time of, the people that are so stressed about, they're literally like clean their house really good, do their spring cleaning before they have surgery because they know they're not going to feel good for a few weeks. And we have farmers and ranchers and business people. Man, I'm going to kill myself for the next 2 months at work because I know I'm going to have this surgery and I don't know how I'm going to feel come back. Yeah. What this procedure does for people is it puts them back in control of the decision making. You don't feel pushed into something by pain and disability. So by giving you control back, you still know how much you hurt. You still know if it's locking. You still know if you're unstable. You still know that you need something else done if you do. Maybe you don't, right? But it at least puts you back in control of, I don't feel pressured to do this now because I can't do anything unless I do that. Yeah. And I think for me, the empowerment of a patient on their healthcare and the decision-making based on, most bad decisions are made because you felt pressured or stressed to do it. And if someone's in a lot of pain, they're probably making not a great decision because they went out of pain. Yeah, I think that may be the best part of the entire procedure is it just puts people kind of back in charge of their own decision making. Yeah. Right. Yeah. So take the power away from the disease and pain is what we're trying to do for people, and that's it's such an easy procedure. The complication rate is that it might not work enough if it's done by the right person in the right way. I mean, there's complications with everything, even though we talk about zero downside because of my smart aleck friends.
Sorry.
Sorry. Like now every time I say it, it's like,
we
right?
try.
But when we say zero downside, we're not saying zero downside. We're saying as compared to everything else we do, there's a lot of easy ways to do some things that can make you better. And by easy, I don't mean, let's just throw a dime at it, right? We're not talking easy. We're talking way less invasive, way simpler. It's not simpler from a healthcare perspective.
Before,
right? It's not simpler. It's just less invasive, and it doesn't sound that you're not going to have a blood clot. You're not going to have pneumonia. You're not going to have a heart attack. You're not going to have a stroke from having a 10-minute procedure. As always, the last thing we want to make sure everyone knows, thank you very much for trusting us to take care of your healthcare. We appreciate the love and trust of our patients, and it is definitely reciprocated. And I think that the appreciation for your trust and involvement in your healthcare decision making is really, really important to us. Thank you.
Thank you.
Thanks, everybody.